This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I'm Mariana Parks, physical therapist and your host, and today I share my conversation with Dr. Tracey Pons, where we discuss complex regional pain syndrome. In our discussion, Dr. Pons covers symptoms, causes, diagnosis, and how CRPS differs from other pain conditions, the role of physical therapy in CRPS treatment and strategies for managing chronic pain, the conceptual model for effective CRPS management that she developed, the importance of a multidisciplinary approach and collaboration with other healthcare providers, and much more. Tracey is New Zealand's first registered physiotherapy pain specialist, awarded in 2016. With a strong academic background, she holds a Post Graduate Diploma, Master's, and PhD in Health Science from the University of Otago. Tracey is passionate about understanding persistent pain, including complex regional pain syndrome and its connection to mental health. She has contributed to international research, peer-reviewed publications, and professional education. If you find our conversation informative, please subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share this episode with colleagues who might benefit from these insights. Thank you for tuning in, and let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like
Welcome to Urban Polling. Discover the Activator program and polls for rehab and balance.
Neck Care.
Treating neck impairment? Get objective neck assessments with the Neck Care system. Learn more at neckcare.com.
Welcome to PT Pro Talk. How are you today?
I'm very good, thank you.
Awesome. I'm glad to have you here. So let's get started just talking a little bit about yourself and your career.
Well, I always have a chuckle in that one of the most wonderful privileges there is in the world is to be able to study. And in today's age, being able to study part-time and work is possible. Whereas prior to, let's say, in the 1990s, early 2000s, distance-related study or being able to, enroll part-time in something wasn't so easily possible. So I'm one of the most privileged people in the world, and I'm so grateful because I did my undergraduate study in South Africa, and then following shifting to New Zealand, commenced a journey towards furthering my understanding of pain with a postgraduate diploma, followed with a master's, followed with a PhD, all part-time while I worked full-time. So that accumulated to a total of 15 years. So I'm so grateful because I have the PhD as the academic side and the research credibility in that sense. But simultaneously, because this wasn't happening in an isolated tower, this was happening while I was working. So I would read a paper and I would see someone the next day for whom what I'd read was so relevant. And this just happened day after day, week after week, month after month, and year after year. So that the habit of reading, having been part of my study for so long, has not changed. In that I will still read, there's a discipline, there's a routine. My life just became that way. And because of the technology, I could do it part-time, distance-based, where the university was the one part of it was within driving distance, but the other one wasn't the main center of the university. There was just a satellite campus that I was attached to. Yeah. So I always encourage anyone listening to anything that I present to never fear furthering your knowledge. And the possibilities now are so much easier than what they were, with that ability to be able to enroll online or part-time, so that what you are learning is relevant to what it is you are actually doing.
Before we continue our conversation, I wanted to take a quick moment to tell you about a special offer from Sarah Health. Visit sarahealth.com/ptprotalk for a 90-day free trial. That's sarahealth.com/ptprotalk. Make RTM simple. Choose Sarah Health. That's sarahealth.com/ptprotalk. And now let's get back to our conversation. Yes, no, that's great to combine your clinical practice with the research and studies, very relevant, right?
Yeah. It was also fun. It was so much fun. Learning is so much fun.
Yeah. And so I know you're big on research on complex regional pain syndrome, right? So could you just tell us a little bit about what is it and how it's different from other chronic pain conditions?
Complex regional pain syndrome is a very interesting and quite debilitating, scary experience, because what happens is, following the injury, recovery would be expected following a fracture or a contusion, a bruise, or a laceration, or soft tissue strain or minor tear. Things get better. And what is so beautiful is that our brain has this mechanism of recognizing when something has been injured and resourcing the area so that it can get better. And the whole mechanism of pain to alert you that, beeper, there's been an injury to a body part is vital. Without having that pain and that warning associated with injury, my consciousness might not be aware of it, and I'll just carry on happily and not realize that I'm about to bleed to death, or I have actually a bone that's fractured. And if I didn't feel sore and thought, oh, this is so cool, I can dance backwards with my knee and let's go to the casino, I would be dead in a very short period of time. What happens with complex regional pain syndrome, and in fact happens with a lot of other persistent pain conditions as well, but in complex regional pain syndrome, it's marked in that the pain warning mechanism does not return to its default resting state following recovery of the tissue. Now, complex regional pain syndrome is divided into two types. There's complex regional pain syndrome type 1 and complex regional pain syndrome type 2, where the type 2 specifically involves a nerve injury. So nerves, when they are injured, can have complicated recoveries. What's so interesting is some don't have complicated recoveries and some do. And why it is that way, we're not sure. And for those who have nerve injuries which don't recover as expected, some may develop complex regional pain syndrome in association with that as well. And that complex regional pain syndrome associated with the type 2 nerve injury is a little bit more tricky and more, can be more painful, slower to respond than complex regional pain syndrome type 1. But essentially what happens is the immune system, the autonomic nervous system, the whole body's inflammatory response to restoration and recovery, instead of following through, resting and becoming less because the tissue is now restored, continues as if the tissue is still injured. So you see color changes, sweating changes, trophic changes to hair and nail growth. And of course, there's this diabolical pain that can be associated also with highly variable temperature changes, where the limb can be freezing cold 1 minute or very hot the next, or consistently one, in that the temperature is, significantly different from the other limb. What's also interesting is complex regional pain syndrome tends to affect the distal limb. It affects an arm or a foot more commonly, but that doesn't mean it doesn't affect the shoulder or the knee or the hip or the spine. But generally speaking, it is seen more in the distal limbs. Yeah, so the person, the hallmark is what the person will tell you, and that is, this pain is terrible. It just doesn't go away. Normally if something's sore and I put my foot up or I put my hand up or I just rest, it will feel less. With complex regional pain syndrome, even if you're resting or sleeping or just trying to relax, it still hurts really, really badly. And then when you try and do things, well, the soreness can become exponential. So that's what it is. Yeah.
Okay, and then you were talking about the type 2, and then how about the type 1?
The type 1 would be following a fracture, but there was no nerve injury, or following a ligament or soft tissue injury, and there's no nerve injury. But what happens is some people say, I must have damaged nerves because there's these skin color changes and temperature changes, and the swelling can be really weird. The swelling can suddenly blow up or suddenly be less. So people go, it feels like there's a damaged nerve inside there. And the pain feels so sore that people think that there must be nerve damage. Yeah.
And the presentation between type 1 and 2 is the same?
Correct. Correct.
Okay.
In terms of what a person would present with, how you diagnose it in terms of the presentation is quite interesting, Mariana, in that for many years it was either overdiagnosed or underdiagnosed because of the various autonomic nervous system changes and the swelling and the pain and the color changes, etc. But what they did was the people who research complex regional pain syndrome met, and they created something which they call the Budapest criteria. And it's a series of signs and symptoms that you need to meet in certain categories. And a certain number of them need to be met to define that you have it or you don't. Many people don't actually present with complex regional pain syndrome. They present with what we would call a regional pain syndrome. And we always say we're so grateful because complex regional pain syndrome is called complex for a very good reason. We don't fully understand how or why it happens. And it's complicated because it involves multi-systems. It's complex because it's not just involving the musculoskeletal system associated with the injury. The autonomic nervous system, the immune system, the endocrine system, the hypothalamic pituitary axis, all sorts of other things, other systems can become involved with this whole process. And in a nutshell, their responses become extremely exaggerated, despite the fact that tissue has actually recovered.
So that's with that criteria, you said that you differentiate regional from complex, right?
Correct. Someone who does not fulfill the Budapest criteria still has a problem with pain. And it's still affecting a region. What's so interesting is it's a complex regional pain syndrome or a regional pain syndrome. And they've been defined like that for a very good reason. A, pain is the hallmark. B, it affects a region. It affects your whole lower leg or your whole arm or your whole leg. It doesn't just affect half the leg or half the foot. It affects a region. And that region, by definition, unless there's complex regional pain syndrome type 2 involved, that region doesn't fit a specific nerve, myotome, or dermatome.
Okay. And on the diagnosis, so how do you differentiate between type 1 and type 2?
It's that straightforward. With type 2, there has been nerve injury. Yeah, and usually we would say for those following surgery who present with complex regional pain syndrome, it's very often type 2, because although the main big nerves weren't damaged, the fact that the skin was cut to access fixing, it's wonderful surgery what the surgeon did, but in order to access that body part inside, they had to excise the skin. And by definition, the skin is full of beautiful nerves. What would we do without those nerves in our skin which wrap around the tiny little arterioles to control our temperature? So because those little nerves get cut, we define it as complex regional pain syndrome type 2.
Okay. And then just to talk about something that I read on your paper that you said sometimes people get confused with chronic regional pain syndrome and complex regional pain syndrome. So let's get that out of the way.
I see it all the time. A referral. Please, Tracey, this person has chronic regional pain syndrome. And I write back saying, please, the nomenclature is complex regional pain syndrome. It's not necessarily chronic. The reason why the chronic has developed is for some, it is a protracted experience. And for some, it does become a chronic. They live with this condition and we don't understand why, but it just isn't possible to resolve. So, and previously, we would say in the 60s, 70s, and 80s, that was more the case, whereas our recognition of it now early, the type of treatment that's applied to it, is much more recognized and acknowledged. So we see now that the prognosis is less likely to be chronic, number one. Where it also gets mixed up, there is in the medical world CLBP, which is chronic low back pain, because typically people with back pain have episodes. There's times where they're fine, but it comes back again and they know what to do. It comes and it passes. So it's just chronic low back pain. It's an unwelcome friend that just comes to visit every now and again. Complex regional pain syndrome is not like that. It's a completely different physiology. It's a completely different scenario. So it's just unfortunate that because of the C, people think that now that they've got this chronic regional pain syndrome and what they see with this red, going almost purple limb that's hot and sweaty and then sometimes freezing cold, and it's so painful. In fact, it's almost impossible to move the ankle or the wrist. They're terrified. And now they're told that it's chronic. It's like, how am I ever going to get better? So one of the most lovely things I have is just to sit people down to go, now let's take a breath. That's not the correct nomenclature. And in fact, it is a process that can be reversed. It's interesting. It's, if you break a bone and if it wasn't malaligned, if it was just cracked, it heals without needing to be pinned or plated, but you do need to immobilize it to allow the bones to unite again and join. Nowadays, with surgery being advanced, often we have plates and pins and all sorts of wonderful things, whereas before, prior to the 50s, everything was just in plaster for an indefinite period of time until everything healed, whereas now that's been made a lot shorter. But ultimately, the healing is something the body does. A surgeon doesn't heal someone. An intervention doesn't heal a person. What an intervention does is help the body to be able to heal optimally. Mm-hmm. A fracture is not fixed. It follows a process to be able to be recovered. And 2 years later, you look at the x-ray and you can't even see where the bone was broken. It has become fixed through a process. And I remind people with complex regional pain syndrome as well, it's a process to recovery. There's not a fix or a magic cure that we're going to suddenly fix this. Mm-hmm. There's a journey towards that place of restoration and recovery.
And then since you mentioned about being reversible, so what are the prognoses? Like when you talk to your patient, how do you explain that to them? And in general, like, do you see people evolving well? How long it usually takes? They might never recover. So how is the prognosis?
Very good question. The prognosis is very difficult to predict. That's why it's called complex regional pain syndrome, because the trajectory in terms of, these signs and symptoms show that you're likely to make a good recovery. These signs and symptoms might be a slower recovery. There are very few factors that predict how it's going to turn out. Mm-hmm. So what the research does show is that allodynia, that's the big word for the skin being so sensitive that even going outside, the wind makes it feel sore, or having the sheet over the foot or over the arm when you sleep is just unbearable. You can't wear trousers. You can only wear shorts. You can't wear shoes on the foot. You can't wear a long sleeve over the arm. That skin sensitivity very, very early on in the stage following an injury, like either immediately or very soon thereafter, the skin just becomes so sensitive. The research shows that with complex regional pain syndrome, that group of people show a poorer recovery. The other research suggests that if it is we're able to address the allodynia early on and get it under control, then the prognosis joins like everybody else because that sensitivity has been reduced. So what we tend to do is where that skin sensitivity is really high, that we focus our treatment in trying to settle that. And there are things that help, and there are things that, despite helping some people, just don't seem to help others. And I think that's the special part of the role that I have, Mariana, in my journey with people, is that because we can't predict what's going to happen, what we have to do is optimize what we can be and do today. Mm-hmm. In one sense, although we can't predict the trajectory, in fact, none of us can predict what tomorrow is going to be like. Yeah, if I've had a straightforward fracture and everything's going according to plan, there is a generalized, this is what fractures do. Or if I've sprained a ligament or torn a ligament, this is what we would expect as recovery. That's normal. But uncertainty in life is, even though there's this generalized thing, I don't know what tomorrow may bring. I'm just grateful I have today. So being able to really focus on optimizing the now. Let's see what we can do to get that pain under control, the inflammation under control, the skin sensitivity under control. Being able to find a place where thinking about movement doesn't hurt. We can create a space where the body, the mind, the soul can be at peace with what's happening right now. And I call it a little bubble, because that little bubble floats on the water of time. And I want that bubble to stay intact. I don't want it to pop. Because whatever it is I have now, I take with me into the uncertainty of time.
Very philosophical.
Well, it is philosophical. I go, yeah, but where's the line? Where do I draw the line between how I think and feel when something's hurting?
Yeah.
There isn't a line. How I think and feel, well, I go back, complex regional pain syndrome or a regional pain syndrome or persistent pain. What's the definition for pain? Well, if you go to the MIASP website, you'll see the definition for pain is a sensory and emotional experience. You cannot separate the two constructs.
Yeah.
So when you're feeling that soreness and you're seeing the swelling, the color changes or swelling changes, and you're feeling that high sensitivity, your mind can run away with all sorts of fears and dreads. And it's so interesting. We feel terrified and frustrated about the now, but for most of us, it's just human nature, Mariana. We start thinking about, oh my gosh, if this is out now, what am I going to be like when I'm 60 or when I'm old? Or how am I going to manage my Christmas holiday at the end of the year?
Yeah.
It's normal for us to be like that. And to be able to realize that the body is not separated from feelings, from thoughts, from your personality, from your intentions, from your social context, from the relationships around you, from your family, from your roots, from the land where you belong. That all integrates. And it's such a privilege, Mariana, to be able to walk alongside people on the journey with persistent pain, whether it's complex regional pain syndrome or not, to help them find that space where the soreness is a physical sensation and there are things they can do to settle it. And there are also things they can do to restore their mind and to restore their emotions so that those vulnerable feelings are reassured, are given comfort. Do you know, Mariana, guess who are the meanest to ourselves? Who's the meanest to us?
Ourselves?
Yes. People will say, my stupid leg. Or I just hate this arm. And I go, oh my gosh, darling. Now imagine if your leg had emotion. How would it feel if you said that to it? Well, I go, how can your leg not have emotion when it's part of your brain and your leg is mapped in your brain? Emotion isn't something we just feel in our head. If I'm happy, woohoo, I'll jump up and down and my arms move. If I'm sad, my body's going to, I don't need to tell you I'm sad. You can see I'm sad with how my body is. So when we say unkind things about ourselves or to our body parts, that does not help the relationship that our mind has, that our soul has with our body. Yeah.
Very interesting. And I wanted to ask you the causes. I know you mentioned like falling an injury, having a nerve damage, surgery. What are other causes that could lead to CRPS?
Complex regional pain syndrome can follow any injury, and there is even record in the literature that it can occur spontaneously, but it's very rare that it would do that. But I have seen it, and more than once. But then I have practiced for many years. It's certainly not something I would see every year. The sources for complex regional pain syndrome was something that I was able to publish, in that I went and did a meta-analysis. Well, didn't do the meta-analysis, but did a systematic literature review. There wasn't enough data for a meta-analysis, which is unfortunate and is often the case for any research with complex regional pain syndrome, because it's not something that's very common. But the factors that were shown to be something where your risk was increased for complex regional pain syndrome to develop potentially is A, if you're a female in your postmenopausal phase. Number 2, if you have a fracture of the distal radius, that's the arm bone at the wrist. And if you have a complex fracture of the ankle. So if it's the most wonderful thing. In the UK, they saw in their one hospital orthopedic department that their percentage of people developing complex regional pain syndrome following the distal radius wrist fractures was quite high. So they decided, right, they're going to do something about this. So looking at those risk factors, being female, being especially postmenopausal, and having a distal radius fracture, they made an algorithm of 8 steps, and they reduced their incidence of complex regional pain syndrome from 25% to 0.1. So we know that although there are these risk factors, there isn't a prognostic thing. If this happens, you're going to develop complex regional pain syndrome. What we know, there are risks, and the risks are simply, having an injury of any form in that sense. But the risk is much higher. So I always tell people, if you have a fracture, and the golden rule is, if after 2 weeks following that fracture, it doesn't matter where it is, but especially if it's in the wrist or in the ankle, and your soreness has not lessened from 5 out of 10, all right, it is still from 5 out of 10 or above, 5, 6, 7, 8, 9, or 10 out of 10, and you are now 2 weeks after the injury, you must go and speak to the person who cares for you, your doctor, or the hospital, or whoever it was that saw you and attended to your injury. It's not necessarily something that would follow only a fracture. It's just that the risk increases for the postmenopausal female with any injury, but especially with the distal radius fracture and the ankle fracture. So we have a little rule in my world, in that if it is that somebody is still 5 out of 10 or more sore 2 weeks following an injury, special attention must be given to them.
And then what would you do? Would you do see if they fit on the criteria to diagnose them? What would be the next steps?
There we go. Now we're talking. Well, there's a world. All right. In my world, the gold standard for understanding pain that's severe, and especially if it's now past the 3-month mark, because it's now defined as persistent. The same rule applies, though, for someone who's presenting now 2 weeks post-injury. The story is the gold standard. You must listen to what a person says. What happens is, as a clinician, if you're busy, or this is the 10th one of these things you've seen today, you can sometimes be a bit blasé and actually not listen with 2 ears. You've got to listen with the one ear with what the person's telling you. Then you've got to listen with your other ear with what they're not telling you, but you can see with their body they are saying. You need to match what they say and what they're not saying, in other words, what they're doing together. And yes, there is some research which suggested that acknowledging, identifying, and being able to diagnose complex regional pain syndrome early was a predictor of a better recovery. Other research showed opposite, in that it didn't matter when the diagnosis was finally made. When it was finally attended to, having perhaps been, it's this, or it's that, and then, oh my gosh, actually it is complex regional pain syndrome. Once it was recognized and the treatment for it started, their recovery wasn't necessarily slower than those for whom it had been diagnosed early. In other words, even if it is diagnosed early, it's not a guarantee that you will make a full recovery. Yeah, it's one of those mysteries. Yeah, most people do, but there are a few who don't. And what it is that makes those few who don't recover, the research, we're not quite sure, but there seems to be a trend which is very similar to any other form of pain problem or any other form of injury. And that is, if it is that you suffer poor mental health, and if it is that your socioeconomic circumstances are deprived, if it is that you've had a lot of exposure to significant trauma, then your prognosis for a full recovery is less likely. Now, as a clinician, helping mental health for someone like myself in persistent pain, we work with a team usually. The biopsychosocial model involving the medical side, the psychological side, the social side, treating a person basically, helping them as a whole, not just seeing them as the ankle or the wrist. So very often we'll have other people involved, but for my role, being able to be sensitive to the experiences of previous trauma, being able to provide care that is trauma-informed, being really caring and sensitive, allowing the person to feel that they are safe here and they have personal agency in being able to have the help they need in their way for their recovery, as well as for people in poor mental health, being able to connect them with the people who will help improve their mental health, and aligning the way my intervention is orientated with the way I suggest what they need to be doing is something which also helps their mental health rather than becoming another barrier or stumbling block. So that's what makes what it is that I do so wonderful and such a special place, because when somebody has these other risk factors showing that their risk for a good recovery is poorer, it's not like, oh my gosh, you sabotaged, it's not going to work. It's, you know what, if we have a look at these things and we get some reassurance and some help around these areas, these other areas that aren't associated with your injury but are interlinked with it, we can help you with a better recovery.
Before we continue, I wanted to share something exciting with you. If you are looking to deepen your understanding of pain mechanisms and treatment strategies, I highly recommend the Role of Hurt course. I took this course myself, and I can tell you it was fantastic. Annie and Melissa are incredibly engaging, and the content is truly top-notch. The course title, Role of Hurt, Nociceptive Pain Mechanisms, Mechanical to Functional Exercise Prescriptions, is happening on March 8th and 9th in Hillsboro, Oregon. As a special bonus for my listeners, you can get $50 off with the promo code WOHPTProTalk. Don't miss out on this opportunity to learn from the best. Visit Eventbrite and search for Role of Hurt to register, then use code WOHPTProTalk at checkout. Now, let's get back to our discussion. And do you usually refer all your patients to other healthcare professionals, or it's more like you feel like the ones that they have higher risk of not progressing well?
Good question. Very good question, because it's an interesting thing. I'm very fortunate where I am in that I am very well resourced with a very broad team in the city that I live in of every imaginable discipline that could help somebody with complex regional pain syndrome. Ranging from a dietitian to a podiatrist, a specialist medical pain physician, occupational therapist, psychotherapist, clinical psychologist, etc. I wouldn't necessarily refer if the person already had somebody who was helping, because there is, some people have perhaps a relationship breakup and are already seeing a counselor, and now they have this injury. It might be that counselor isn't experienced to be able to help with the pain thing, but they need to continue with that relationship counseling. So again, the gold standard is the story listening. Some people are just so happy to talk about their pain with a clinical psychologist. Other people go, but I'm fine in my head. I'm terrified. It's like, what's wrong? I've got a problem with my leg or my ankle, and now you're telling me I've got a problem in my head as well. And I think that's one of the loveliest parts of being able to be accurate in the way that we listen and very sensitive, because when a person is ready, they will embrace what it is they need, because people know what it is that they need. It's not my job to tell anybody this is what you need and you must do this. It's my job to walk alongside them in the journey and help them to discover, so that they're the ones saying to me, Tracey, you know what you're talking about and the thoughts and feelings I've been having, I've just found myself feeling overwhelmed. Do you think you could arrange that I, talk to somebody, and I'd prefer a male or a female, whichever? That to me is the best. Then I know that I have really helped, because this person has come to discover what it is they need themselves.
Mm-hmm.
I always say, when you work with complex regional pain syndrome or persistent pain, you are the person alongside your patient. And I go, patient? They're people. You're alongside this person who has a problem with whatever it is. And your job is to help them find the inner strength that was always there. Every human has the most incredible inner strength. But what happens is, because of the pain, because of the circumstance, sometimes injuring events are very traumatizing. The dog had to be put down because of what happened. That was more agonizing than the fact that you got fractured in the car accident. The car accident killed the dog. All it did was fracture my leg, but now I'm stuck with complex regional pain syndrome. But yeah, it's like I'm more freaked out about missing my dog.
Mm-hmm. Yeah.
That person is with you and still they're able to tell you they're really missing their dog. I go, wow, you've got amazing strength. You are able to be present with me now. You are highly distressed about your missing your dog, and you made it in time to your appointment. That is amazing. Now, because of that, your personal resources, the energy your brain and body need to help your recovery, are being eroded, because you're having to cope with all this other stuff that's associated with injury. I can't fix those things, but I can walk alongside you and help you discover what it is that you have within you that can help you to cope, resolve, overcome, etc.
Mm-hmm. And when you refer them out, is usually more related to mental health?
No, I'll be everything. For some, we need a podiatrist to help. For many, the hand therapists are involved with various splinting or specific exercises and rehab for hand-related things. The specialist medical pain physicians are for complex regional pain syndrome, there's medications and interventions that can be helpful, not always, like anything. Some people do really well. Some people take exactly the same medication with a similar presentation and just don't have the same positive effect. So, yeah, but as a rule of thumb, we are very fortunate here in New Zealand in that complex regional pain syndrome almost automatically is accepted to be something that needs a team approach, so that the people who would be needed, perhaps an occupational therapist to help with certain things at home, and then the physio, obviously, with the exercises, and the medical people for the necessary interventions, and the psychologists to help, manage these just feeling just so totally overwhelmed and devastated by the pain. You've lost your job now because of the pain. The psychologist who's going to help you with pain isn't looking at necessarily resolving mental health or past trauma. But clearly that intertwines, but helping you cope with what you have to navigate with now. You've lost your job and you have this pain. It's like your whole life's changed. You were a busy, fit, active person for X number of years, and suddenly your life's ground to a halt. So it's no wonder you're feeling anxious. It's no wonder you're feeling low. You don't need to beat yourself up for feeling that. And the psychologist is there to be able to help you work through that.
Mm-hmm. And I know you have developed a conceptual model, right?
Yes. Yeah, I'm the only one in the world.
Let's talk about that. So tell us about that.
Yeah, what happened was with the research that I did, I followed up. I initially had 72 people who have complex regional pain syndrome referred to the project across the South Island, and I followed them up for a whole year. And then I categorized absolutely everything that was done to provide treatment from, you name it, anybody and everybody, because I accessed the clinical record and notes from all the various disciplines, but primarily from the physio. And then I had an independent interviewer who phoned them at 6 weeks, well, initially upon referral, 6 weeks later, 6 months later, and a year later. And then what I did was looked at the kind of recovery they made with all the different things that we measure complex regional pain syndrome with, as well as their function as quality of life, the relationship that they had with the people who were helping them, and then did a whole lot of statistical analysis to find what helped the most. And it was interesting. There wasn't a huge amount to show necessarily that this is the gold thing. This is what makes the biggest difference. But most, 45% of the cohort made an absolutely full recovery. Then another sort of 30-40% made, a good recovery, but there was still a bit of this and a bit of that, but it wasn't bad. Life had returned to normal. There was only a very small group who didn't make that full recovery. So from all that data, I created this model which gave the idea of what would be the best way to ensure that you are doing the right things to make a good recovery possible. Yeah. So there's what I have is 4 boxes in the corner of those who go and look at my paper, and anyone can ask me to access it if they want. Whereas there's that whole concept of the way the relationship and the therapist, who's the physio, interacts. Then there's the medical side care. Then there's the psychological care if it's necessary. And then on the top of the model are 2 foundations. The one is that complex regional pain syndrome can be prevented. We know that. In that, if it is right in the early stages, the Budapest criteria are applied and it is identified. Although it's not a guarantee of a full recovery, it makes common sense. The sooner we start the appropriate help, the better. Yeah, it's not like hope is lost. If due to circumstances you're out in the wop-wops and you weren't able to get help that was appropriate till 6 months later because you were abroad or whatever, your recovery will still be all right. But it's common sense that the sooner we start, the better. And then underneath is the other foundation, which is mental health. Because of the pain, because of the change in life, support for you as the person experiencing complex regional pain syndrome and taking responsibility for your mental health is a priority. Because we know from all sorts of other research, and my study showed the same, that those with lower mood, for whatever reason, didn't show quite as good a recovery, although it wasn't bad, the better mood as a baseline. And, what determines mood? Our feelings go up and down. We can't trust them. But sometimes we just do find that, I was vulnerable for 3 months prior to the injury. My job had been stressful. My mum had been ill. My dog had been sick, whatever. And then there's the injury. So it's like a last straw. So the mood, why I put it there was to feel comfortable as the person with complex regional pain syndrome to say, please, would you help me? I'm just feeling so on edge. In other words, not to feel ashamed of these other strong feelings that now accompany the experience of the pain and the whole experience actually being traumatizing because there was an injury that wasn't very nice. And now there's a whole lot of pain. And I might have had to have surgery and I might have got infection either before or after this. Life is complicated. So The whole thing of the mental health being the bottom foundation is about feeling okay about saying, this is really hard and I just feel like I want to cry all the time. Not feeling like you must cover that up and pretend to be brave. Yeah, and the therapist as well, because the two boxes on the top are it's the type of therapy and the way the therapy is done, is being able to have a way of being alongside this person to help them feel comfortable with telling you that. So that then you can choose. Some people would do better with a clinical psychologist. Others would do better with a counselor. Knowing what discipline offers what and listening to the story of the person helps you to be able to identify what it is they need, but they need to feel comfortable about telling you what it is they're really feeling. Because when we feel low and when we're traumatized by this whole pain experience, we feel bad because we're not strong on getting better. Mm-hmm. So you're low, but then you beat yourself up for feeling low. Mm-hmm. And then that doesn't help the pain. That doesn't help how grumpy you are with your partner. That doesn't help that you've got to go and fetch the mail from the letterbox and you're very worried because it's going to be another bill and you don't know how you're going to pay for it. So by the time you come to physio, you're like,
And like now thinking about our musculoskeletal therapists here, what are the things that you do in the treatment, like to help them? Do they have reduced range of motion? Like, what are the things that you do to help them physically?
And that's what that model is all about. The first, because there's these 4 boxes and then there's a circle with 4 boxes that rotate, and these are held together with these 2 foundations. Physios need to be aware there are things we can do to prevent that it happens to start with in terms of what is immediately done following an injury. And secondly, that being aware and sensitive to the whole mental health interaction is important. The number one thing for complex regional pain syndrome is not, come on, let's get that leg going, is what can we do to settle the pain? And this is, I love it, mirrored reflection, visualization, graded motor imagery. There's a whole host of things that can be very helpful there. TENS is not usually helpful for high levels of allodynia and acute complex regional pain syndrome, but later on it can be. TENS is not something used initially. Often being able to get into water. Yes, sometimes with the high skin sensitivity, it's not possible. Some people don't like the warm water. Some people don't like the cold. But being able to move without so much weight on that limb can be liberating. Yeah. Mm-hmm. And then there's medication prescriptions as well. So what the number one thing with complex regional pain syndrome is to just take a break, step back and go, what makes this pain feel worse? And what we are going to do right now that's going to help that pain to feel better. So when you walk out my clinic, it is already feeling less sore. A good example is when the limbs are, say you want to move your hand for an exercise and they're here, if you cross them over into the other side, I've seen it and the research shows that having this affected side in the unaffected body side makes it feel easier. I've seen people where, as we've changed over to the other side, a lot of the color changes and difficulties settle. Now, they come back when you go there, but at least you can have a reprieve while it's there. And that's when you can start all the other types of mirrored reflection visualization. And what is so helpful, just to get the whole body to feel, because I'm like this because of the soreness and I've had to get to this appointment and I arrived late or I got here on time and the traffic was bad. To be able to help people connect their body with who it is that they are, so that who it is that they are inside their body feels safe, even though it's sore. So using breathing, using techniques that help the whole body to feel at rest, to feel safe, are a foundation. Once I've found the place that helps to reduce the pain, second box is into education about it, explaining why and how. Yeah, some people don't need to know all the ins and outs, but just saying you must do it because it works, to me is an insult to the person who's alongside you, because you're wanting to help them discover the strength that they have within them, which means they need to understand the this and the that's associated with it. Not about everything in general, but about what's relevant for them. And then everything is progressed according to tolerance, and it's not focused on, right, we must get so much range for the wrist or the ankle. Of course we want to, but what we're going to focus rather on is, if we were in the kitchen and we were needing to do this or that, that's the kind of movement I'm going to be need to doing. So rather than thinking about, I need to get this far, I can think about how lifting a spoon up or using my knife, orientating the movement to be more functionally relevant is much more important. Yeah.
Okay, so common things: go to the water, try to make it easier for them to move, breathing, the mirror, right, that you said, education. You said the TENS later on,
Yes,
right?
sometimes TENS can be very helpful. Yeah.
Okay. Any like desensitization, like, with the skin?
Oh, yeah. Yes, the desensitization, again, depending on, that's part of the decreasing the pain, is desensitizing. Absolutely. The desensitizing therapies there's a huge range. And those are also can be really effective. Yeah. Not just in decreasing the whole skin sensitivity, but just decreasing the whole pain as a whole. Because we know once the skin is less sensitive, everything does tend to settle as well. Not totally, but it's a start.
Mm-hmm. And you said that we can prevent, right, that from progressing. So how do you prevent?
Well, that's to do with the people who see the injury initially. And it goes, the red flag is there's more soreness than 5 out of 10.
Mm-hmm.
All right. And it's 2 weeks later. It shouldn't be doing this. It should have dropped somewhere below 5 after 2 weeks. And in terms of what it is that the pain service, that's when the GP or the physio need to make a referral to someone who's experienced with pain to go, right. They are often sent to me, it's not complex regional pain syndrome, it's just a regional pain syndrome, or it's not full, it's not meeting the Budapest criteria yet, but it's looking like it could. So we're going to get our treatment and our intervention going. And for me, the biggest thing is people go, they told me it's terrible, I've got chronic regional pain syndrome. That's what they said in the hospital. And I go, bless them, I know those people at the hospital. It must have been a really something day, or because the people I know, they wouldn't have said that. Must have been just perhaps a locum on for the day or something, because that would have terrified to have you have a professional tell that to you. A, it's complex regional pain syndrome because we don't fully understand how and why it happens, and it involves multi-systems. And B, it's not terrible. It is horrible right now, but it's going to be able to get better. So, yeah, that language when, things aren't improving as we would expect, as a clinician, to be very careful about the language that we use so that we don't actually make the poor person more terrified. Yeah.
Mm-hmm. And then, like, prevention-wise, is like medication. Is related to medication. Is related to not immobilizing for too long the limb, or.
You've done a lot of reading. I'm impressed. Absolutely. The prevention is two extremes. People can either be doing too much or they can be doing too little, which is not enough. There is a risk for complex regional pain syndrome to develop following any injury we don't know why, except for those other factors. But if it is you're going to do too much, ignore the rules, you might increase your risk. But we also know that there's other research which says the medical profession tend to be a little bit too overprotective, and in fact breaking a few little rules here or there every now and again. Yeah, we go, please don't, but be honest. Say, instead of hiding it, just say, you know what, I didn't listen to you, I went for a longer run, and you know what, I was actually okay. Or I don't know why it's bad, and you've actually hidden, you haven't told the truth that you went for a longer run and it got far worse. Mm-hmm. So this is, whereas other people are terrified. It's actually safe to move, even though it does hurt a little bit. It's perfectly safe. It is going to hurt a little bit, and that's okay. And you'll find it's just lovely with complex regional pain syndrome. We find it hurts a little bit, so we go to what it is that we use as our pain modulation, the thing that we know takes pain away. We go back and we do it again, and we find it doesn't hurt the second time. And if it was that it started, go back to our thing that helps take the pain away, and we find, we can do it a third time and it's not hurting. Whereas if because of the first time it just hurt and we not going to do it anymore, that's not going to help either.
Mm-hmm. Okay, I know you're pretty much out of time. So before I let you go, any resources, or if the audience wants to learn more about it, anything that you recommend them to go read?
The NOI website, NOI, N-O-I, run by Laura Mosley, has some very interesting courses as well as resources. The Explain Pain book that they provide is very helpful. They also, and the Orientate is UK-based. There's an app for the graded motor imagery that is shown to be helpful in the early stages of complex regional pain syndrome. Mm-hmm. Sometimes there are some places where, like anything on the internet, you can be given information that makes you scared. I say, if the information makes you scared, you put it off. If the information is encouraging, the information is like that person alongside you, encouraging to find the strength that you already have there within you, you know this information is good for you. If the information scares you, just shut it down and then go and talk to the person who helps you about, I read this and it made me feel scared. And then the person who's treating you can help explain what it was they were actually meaning. Or, I know that website. I don't trust it. Yeah.
Okay. And if people, I know you're very busy, but if people want to find you or contact you potentially, is that a way that they can
I've got a website. I have a website. Yeah.
Okay.
Dr. Tracey Pons, Specialist Pain Physio.
Okay. Yeah. Sounds good. I'll add that to the show notes. Anything else before we wrap up?
Just thank you for this time. And my message to everyone out there is things can get better. What happens is we become frightened and we inhibit our own ability to get better because we become so frightened. Tell the person who helps you about what you're frightened of and help them help you to overcome being so afraid.
Awesome. Tracey, thank you so much for your time and to sharing all your knowledge with us. I appreciate it.
It's my pleasure. Thank you, Mariana. Have a lovely day. Bye.
Thank you. You too. Bye. That's all for today's episode of PT Pro Talk. We hope you enjoyed this discussion. Be sure to follow us wherever you listen to podcasts so you'll be notified when we release future episodes. You can also join our email list at ptprotalk.com to receive updates and access new episodes. If you have ever gotten value from the show, please take a moment to leave us a 5-star review. It always makes my day and it really helps us out. If you have any guests or topics you'd like to see on the show, let us know by answering a quick survey. You can find the link in the show notes along with more information about our guests, resources, website, and social media. Thanks again for listening, and until next time.